Hello and welcome back. So today I'll be talking about an approach to vomiting and abdominal pain, part 2.4, that is focal localized pain due to parenchymal organ distension, particularly hepatic distension. So this time I'll be starting with a case because I want to highlight. Till now we've discussed acute pancreatitis and acute mesenteric ischemia. Um, as an differentiated acute mesenteric ischemia from intestinal obstruction as causes of abdominal pain. But now the cases become, there are certain points in the cases that need to be discussed in in the correct context. So we need to discuss the cases in the light of that. So the case is a 35-year-old lady who does not have any known who has no known prior comorbidities, who has no history of substance use or abuse, who is now presented with an abdominal pain for the last 6 weeks. The pain was gradual onset, persistent, non-progressive, deep-seated, right upper quadrant, dull aching, catching type of pain, which was moderate to severe in intensity, and radiation. There was some radiation of the pain to the right shoulder tip. It was in turn also associated with abdominal distension, which was gradual onset of persistent, progressive, diffuse abdominal distension without any episodes of vomiting or altered bowel habits. As far as the negative history is concerned, there was no negative history of shortness of breath or cough, and there was no significant treatment history. On examination, she had mild bilateral pitting pedal edema, but no other features of chronic liver disease. Vitals were within normal limits. And on abdominal examination, she had right upper quadrant tenderness. However, there was no guarding and there was shifting dullness, indicating there was fluid in the abdomen. Outside investigations that were available at the time of initial evaluation were suggestive of moderate ascites. The liver was enlarged, but there were no features of cirrhosis or portal hypertension in the ultrasound. So, based on what we know as of now, the patient naturally has significant localized abdominal pain without any vomiting, with and which is in this case associated with ascites. So we're not discussing ascites as of right now. We'll get to it subsequently. But the differential diagnosis for acute abdominal pain without vomiting would be peritonitis, hollow viscous distension, although vomiting would be expected in that situation in most cases. Acute mesenteric ischemia, again, vomiting would be expected in would not be expected in that case. Parenchymal organ obstruction or rather distension. Again, that might be associated with vomiting, may not be associated with vomiting, and acute pancreatitis, but acute pancreatitis would be associated with vomiting most of the time. So these are our five differentials. Uh, However, as you can see, I have highlighted the important points in the history here. So A, that the pain is in the right upper quadrant. Second thing is that it is not associated with any episodes of vomiting, and there are no there's no alteration in bowel habits. And importantly, there is no guarding. So if there is no guarding, peritonitis becomes significantly less likely. Then similarly, because there is no alteration in bowel habits, acute mesenteric ischemia as well becomes quite unlikely, and because of the right upper quadrant location of the pain. Then acute pancreatitis becomes unlikely because of the location of the pain, the lack of vomiting, and the lack of the characteristic postural variation in pain that we've discussed. So again, ascites could occur with peritonitis, and it might mask peritonitis, but again, the pain is very local. It is not diffuse, so it seems unlikely that there is a peritonitis with ascites. Uh, Ascites with acute mesenteric ischemia could technically occur, say, if this was lupus mesenteric vasculitis, but again, we'll need to put a pin in that. I don't think there is anything to suggest in this patient that there is SLE. Again, acute pancreatitis can also cause ascites, but again, the pain doesn't point to acute pancreatitis. So all three entities that I have crossed out can technically cause ascites in specific scenarios, but again, in this particular case, they are not valid differentials. So we'll remove those from our differential diagnosis. So finally, we have a significant localized abdominal pain without vomiting with ascites and likely secondary to parenchymal organ distension, and less likely there is also a small possibility of there being an of a hollow viscous obstruction, but again in the specific scenario of lupus mesenteric vasculitis. So in this situation I will not consider that in the differential as of now, unless something else may prompts me to. Now, of which organ is affected? There are three parenchymal organs that can be distended. It could be the liver, it could be the spleen, it could be the kidney. So obviously, since it is right upper quadrant, we are talking about the liver. Okay. So nothing is localized abdominal pain due to the parenchymal organ distension can be due to hepatic distension, could be due to splenic distension, could be renal distension. Now, in today's discussion, we are going to be discussing regarding the possibility of hepatic distension and how we differentiate it from the different causes of hepatic distension. I will also in the beginning compare that to splenic and renal distension because of overlap in etiology based on the cause of the distension. Okay, for example, whether it is hepatic venous thrombosis or splenic venous thrombosis or renal venous thrombosis, or the etiology is often often common, as in the etiological workup would be common. However, the presentation is highly dependent on the anatomical localization of the organ affected. So, as far as presentation is concerned, we'll be restricting ourselves to the hepatic symptomatology for this discussion. But etiological workup I'll discuss in general in the beginning, and then we'll go into details in the next subsequent videos. So again, since it is right upper quadrant pain, it is not the spleen and it is not the kidney, so it's likely the liver. Okay, but the question does arise, why? Now, so getting to the discussion proper, this is approach to vomiting and or abdominal pain part 2.4. uh, Today we'll compare and contrast between the 7 causes of pain arising from parenchymal organ capsular distension. So this includes hepatic causes like obstruction of, see, has got the liver has got venous flow out of it. It has got biliary drainage out of it like this. Okay, and there is obviously some parenchymal tissue within the liver. So if you have hepatic enlargement, it would likely be due to either an obstruction to hepatic venous outflow, or due to an obstruction to biliary outflow, or due to a sudden increase in the amount of tissue that is present within the liver. So that is why I classify them as causes of biliary obstruction, hepatic venous obstruction, and your diffuse parenchymal inflammation of the liver. Then we'll be talking about splenic enlargement. This would include causes of rapid increase in splenic size. We've discussed previously in our talk on approach to generalized lymphadenopathy and our hepatosplenomegaly regarding the mechanisms and causes of splenic enlargement. But at that time, I did not talk about the rate of enlargement. Okay, so it is only those disorders which cause rapid enlargement or very significant enlargement that cause pain. So we'll be restricting our discussion to that in this series. Then we'll talk about splenic arterial infarction, and we'll talk about renal diffuse inflammation, infarction, and obstruction to urinary outflow. Again, because the urine and blood leaves the kidney, so we'll have to talk about urinary outflow obstruction as well as renal vein thrombosis, which I'll be using an analogy to compare it to hepatic vein thrombosis. So now, importantly, infarction is not been will not be discussed in case of the liver, because infarction is not of the liver doesn't really result in any symptoms except for obstructive changes or subsequently development of obstructive jaundice. So I'll discuss that when we talk about the hepatic venous disorder, hepatic disorders of the hepatic vasculature subsequently in this series. Okay. Now, Finally, we'll learn how distension of parenchymal organs can be also be due to parenchymal bleeding, that is bleeding into the organ, and possible causes of that. Then we'll describe how distension of parenchymal organs due to parenchymal bleeding causes abdominal pain. We'll enumerate the causes of biliary outflow obstruction. Uh, at the same time, because the ureter is also a similar, tube carrying urine into the bladder, where the bile is carried by the common bile duct. The etiological workup for what is causing what is analogous. So we'll discuss I will compare the two in a subsequent slide. Then we'll enumerate the causes of hepatic venous outflow to obstruction, with specific emphasis on sinusoidal obstruction syndrome, Budd-Chiari syndrome, as well as elevation in right atrial pressure that could be secondary to right ventricular failure. We'll review the clinical presentation of various vascular disorders of the liver, because I feel this is the best site to discuss it. And then we'll review the causes of diffuse hepatic inflammation, specific emphasis on how to evaluate acute and chronic. I'll not be going into the etiologies of each disorder in this particular series. I'll reserve that for a later series, on probably on hyperbilirubinemia and on ascites. Okay, fine. Now, like I said, there are 7 causes of parenchymal distension, excluding bleeding into the hepatic renal or splenic parenchyma. So the first is obstruction to biliary outflow. So like we just saw, the liver has blood going out of it. That is, it has a venous drainage, and it has got bile draining out of it. That is got a common bile duct, and the bile is draining out like this. Okay, and actually inside the liver there are multiple biliary canaliculi. Now, finally, the liver has got obviously hepatocytes within its parenchyma, and those there could be inflammation around those cells, and there could be infiltration of new cells. So either we have a biliary obstruction, or we have a hepatic venous obstruction, outflow obstruction, or we have hepatic inflammation. These are the causes of sudden enlargement in the size of the liver. Then we have rapid splenic enlargement with an emphasis on rapid. We have splenic infarction, that is arterial infarction. We have renal infarction, and we have renal inflammation. Now, importantly, I have not talked about splenic vein thrombosis, and I have not talked about renal vein thrombosis, even though I have talked about hepatic venous thrombosis obstruction. So the reason is because they're very analogous in terms of their causes. So the evaluation remains very similar. So we'll talk about the site of origin of pain. We'll talk about the radiation of pain. We'll talk about what are the associated features, and what are the whether or not there is vomiting associated with these presentations. So uh, obviously, in all 3 causes of hepatic enlargement, you have got pain in the right upper quadrant, because that is where the liver is located in most people. Then we have radiation. Radiation of pain is right to the right shoulder and to the scapular tip. So that is why our case is quite clearly due to hepatic distension. In case of biliary obstruction, naturally the patient develops jaundice, and it will be direct hyperbilirubinemia, and usually there is prominent vomiting. In case of hepatic venous obstruction, ascites is almost always a given. So that is why our patient likely has hepatic venous congestion. And in case of hepatic inflammation, jaundice may or may not be there. Vomiting is often very prominent, especially in case of acute hepatitis. And however, we'll see how to evaluate those cases, but our case clearly is not that. Then we have rapid splenic enlargement and splenic infarct. The spleen is located in the left upper quadrant, so that is where the pain arises from, and refers to the left shoulder tip. It's called the Kerr sign in surgery. Uh, then we have no clear symptoms associated with either of these two types of pathologies. Then in case of renal infarction, renal inflammation, we have renal angle pain, that is at the back, the renal angle in the back, and radiation is towards the back. It is associated, sometimes may be associated with azotemia, although it may not be. Infarction may be associated with significant increases in blood pressure. Renal inflammation usually is associated with some degree of vomiting, infarction less so. Okay. Now, coming to the etiology, In case of biliary obstruction, since it's a tube, there could be external compression of the tube, there could be a thickening of the wall of the tube, and there could be some luminal pathology obstruction obstructing the tube from within. In case of obstruction to hepatic venous congestion or renal outflow, there could be obstruction at the level of the hepatic veins. That would be Budd-Chiari syndrome, or the inferior vena cava before it goes into the right atrium. That would also be Budd-Chiari syndrome. It could be at the level of the hepatic sinusoid. So we've got here the hepatic veins are formed by hepatic sinusoids. So hepatic sinusoids, multiple hepatic sinusoids go and join together, and they form one hepatic vein. And the hepatic vein, the four hepatic veins go and drain into the IVC. Okay, so there are three major hepatic veins, and there is one minor hepatic vein. We'll be discussing the anatomy in more detail when we talk about the imaging in the diagnosis of these disorders. Okay, so the obstruction can be at the level of the sinusoid. It could be at the level of the hepatic veins themselves, or it could be at the level of the inferior vena cava. Hepatic veins and inferior vena cava is then called Budd-Chiari syndrome. And if you have an elevation in right atrial pressure, it is usually due to right ventricular failure. So that is the third cause. Then we have our hepatic inflammation and rapid splenic enlargement. Now, see, both of them are essentially due to diffuse processes affecting the liver and the spleen. And actually, when a process affects the liver, invariably it affects the spleen and vice versa. So, in both cases, there could be diffuse disorders, which we'll discuss, and there could be localized collections like hepatic splenic abscesses. Then we have splenic infarction and renal infarction. Again, both the operative word there being infarction, the type of pathology. So in both cases, it could be thrombi that are being thrown from the heart. It could be an artery to artery embolism. It could be vessels that are getting inflamed and therefore the blood supply is getting blocked. And rarely there is thrombosis of vessels, although this rarely happens with the splenic artery. It more commonly happens with the renal artery. And finally, we have renal inflammation. When there is diffuse renal inflammation and there is no inflammatory agent there, or there is no bacterial infection rather, more than tubercular or fungal infection, we call that interstitial nephritis. If there is an infective agent, that we call that pyelonephritis. Finally, there could be localized connection, that would be renal abscess. So this is the general format of how we evaluate patients with suspected parenchymal organ distension. Okay, so as you can see, the common clinical features in these cases are due to the organ that is affected, and therefore the sensory efferents that are being activated. Whereas the etiology depends primarily on the similarities in the common pathophysiological mechanisms. Thus, splenic and renal vein congestion happen due to splenic and renal vein obstruction, respectively. These resemble other causes of respective parenchymal organ distension, but that is they resemble splenic, enlargement and renal enlargement, respectively. But etiologically, they are much more similar, or the evaluation becomes that of hepatic venous obstruction, which we'll just come to. Okay, now intraparenchymal bleeding into the liver, the spleen, and the kidney produces a very similar pain. Such a bleed within the renal neoplasm has an eponym, which we'll talk about. These bleeds are almost always related to at least one, but sometimes multiple causes. So it could be a systemic coagulation disorder. It could be a structurally defective blood vessel within the parenchymal organ. Such a blood vessel may be part of an arteriovenous malformation. It may be part of a pseudo aneurysm, or it may be part of neovascularization within a neoplastic process. So this kind of neoplasm related hepatic bleed is known as Vandalic syndrome. Okay, standard MCQ question in surgery. Now, coming to the first clinical cause, that clinical evaluation, that is evaluation of biliary obstruction. Now, what I like to do is I'd like to divide it into actual obstruction of the common bile duct versus obstruction of the portal tracts. So, as is quite obvious, the portal tract ductules joined, multiple ductules joined together to form the hepatic and the right and left hepatic ducts, which then join together to form the common hepatic duct, which is joined by the cystic duct to form the common bile duct. Okay, so this is the general anatomy. Again, we'll be getting to that in when we talk about the radiology in the diagnosis of the disorders. But more importantly, from the point of view of evaluation, what is important to us is what may be causing obstruction at a particular point. So again, because both of these are tubes, the obstruction could be caused by an extrinsic or outside wall process. It could be caused by a wall process, that is within the wall of the common bile duct or the within the portal tract, or it could be due to an intraluminal process, that could be an endoluminal or inside the lumen process. Now again, outside the wall, the process could be inflammatory, or it could be neoplastic. In the wall, it could be an ischemic process, particularly as we know, the hepatic artery primarily supplies uh, the 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 branches of the or the tributaries of the hepatic ducts. Uh, they do not get a supply from the portal veins. Now, it could be inflammatory and it could be neoplastic. So let's see what might be the causes. So naturally, in case of portal tract obstruction, regenerating nodules within the parenchyma of the liver can compress surrounding portal tracts. This happens classically in case of cirrhosis. Then we can have CBD obstruction due to external compression by any type of inflammatory or neoplastic process, and there's no point in listing them out. It depends on the location, the imaging. So we'll discuss that more when we talk about imaging. Then again, in the case of the portal tract, any kind of inflammatory infiltration, I recall using a mnemonic, that is the gel. So gel may G here stands for granulomatous disorders. This is particularly the case with sarcoidosis and inflammatory bowel disease, that is Crohn's disease. E stands for eosinophilic disorders, so that would be parasitic and drug induced, and L would be lymphocytic. But lymphocytic disorders usually don't, involve the outside of the wall. They actually are directed against the wall. So we'll just talk about that. That would be primary biliary cholangitis. Finally, any neoplastic process can infiltrate into the portal tract. Classically, hematological neoplasms, but solid malignancies can also metastasize there. Then you can have proper strictures, that is narrowing of the CBD in CDPD wall. That could be ischemic or inflammatory in origin. In case of ischemia, the portal tract obstruction can happen due to hepatic artery obstruction, which we'll be discussing as a type of hepatic vascular disorders in a few slides. Then, like I said, inflammation in the wall or around the wall of the portal tract would be primary biliary cholangitis. Neoplastic pathology within the wall would be cholangiocarcinoma of the CBD, would be cholangiocarcinoma, whereas within the wall of the portal tract would be hepatocellular carcinoma. Finally, inside the wall of the CBD, you could have stones and parasites. Obviously, the lumen of the portal tracts is too small for anything to obstruct it from within, so there's nothing there. Okay. Now, urinary tract obstruction is actually very similar in terms of causes to biliary tract obstruction, but there is a important difference, that is the obstruction can occur at multiple levels. So again, we'll discuss this more when we talk about the radiology of how we diagnose these disorders. So the obstruction can be at the level of the renal pelvis, then it could be at the level of the ureters, which again could be in turn at the level of the pelvic-ureteric junction, the retroperitoneal course of the ureter outside of the pelvis, retroperitoneal course of the ureter out inside of the pelvis, and could also be inside the bladder, and it could then again be at the bladder outlet, that is on the prostate. So again, at each location the anatomy is different, and therefore the possible causes of external obstruction change. However, the wall disorders and the intraluminal disorders are the same. So wall disorders would be inflammation or ischemia or neoplasm, and the intraluminal disorders would obviously be stones. Very rarely, uh, okay, it will always be stones technically. Okay, bladder stones would be a consideration, and prostatic stones also in specific scenarios. Now, coming to evaluation of hepatic venous congestion, as I've discussed, this is the liver. And as you can see, I've shown the three main hepatic veins that are draining into the inferior vena cava, and finally they drain into the right atrium, and from there blood would go to the right ventricle. And I've also taken a section of the parenchyma of the liver and shown you the portal tract, which contains the a branch of the portal vein. Okay, it contains a tributary of the hepatic duct or the biliary system. Okay, and this is the hepatic artery branch. All three goes together in the portal tract, and the portal vein then opens into the hepatic sinusoids. So these are the sinusoids, the hepatic sinusoids, and finally drains into the hepatic vein. So as we've just discussed, obstruction to venous outflow of the liver could be at the level of the sinusoids. So that would be called sinusoidal obstruction syndrome. It could be at the level of the hepatic vein, or rather here, or IVC, which is then called Budd-Chiari syndrome, and it could be due to increased RA pressures. Okay, so these are the three possible anatomical locations, and at each location the etiology varies. Okay, so there is passive hepatic congestion due to increased right atrial pressure. There is hepatic venous obstruction due to hepatic, venous outflow obstruction, which is then called Budd-Chiari syndrome, and we've got your obstruction to the hepatic sinusoids, which is then we call what is called sinusoidal obstruction syndrome, SOS. Okay, now passive hepatic congestion due to right atrial pressure will be reviewed under approach to peripheral edema part 6. Okay, which is an upcoming video, because again that has to be discussed in the context of restrictive cardiomyopathy, etc. So I'll not be going to that right now. So today we'll be talking, restricting ourselves to sinusoidal obstruction syndrome. Now this is also known as hepatic veno-occlusive disease. It almost exclusively develops in very specific clinical scenarios. That is, it happens in post hematopoietic stem cell transplant patients on chemotherapy with gemtuzumab osagamycin, cyclophosphamide, dacarbazine, melphan, and busulfan. So cyclophosphamide, importantly, very important from a rheumatology perspective, and platinum coordination compounds, specifically carboplatin and oxaliplatin. It also happens with azathioprine, which again is important from our perspective in rheumatology. And then it happens when it's been recorded with herbal tea exposure, that is Jamaican imbibe bush tea or Caribbean tea. Now, the clinical presentation is actually quite characteristic. It's a triad of three features developing around 1 to 3 weeks post transplantation. First, because being right upper quadrant pain, as would be expected in this discussion. Second, being weight gain due to fluid retention, which, as we discussed, is ascites, usually a 2% increase in the weight from baseline. Three is a rise in the total bilirubin to more than 2 milligram per deciliter. Uh, Now, there is an interesting monogenic cause of sinusoidal obstruction syndrome, which is actually a type of primary immunodeficiency, a human inborn error of immunity, which is a primary immunodeficiency due to a specific protein called SP110. So, this mutation has been reported in as an autosomal recessive disorder in Pakistani origin patients in the West, but obviously, Pakistani origin patients would have overlapping common genetic traits with at least North Indian populations. There's an increased risk of opportunistic infections. I use a mnemonic CRP to remember them. That is cytomegalovirus, rotavirus, and pneumocystis carinii occurring in the first 1 year of life. Then there is cerebral necrosis due to cerebral venous occlusive disease. So this is the characteristic presentation. Again, this is a cause of sinusoidal obstruction syndrome in the absence of chemotherapy. Okay. Now talking about Budd-Chiari syndrome. Budd-Chiari syndrome can be due to primary Budd-Chiari syndrome. It could be secondary. Now primary means there is thrombosis within the hepatic vein. The secondary means there is extrinsic compression of the hepatic vein due to any type of structure surrounding structure. So the causes, the most routinely quoted cause in terms of decreasing order of likelihood are: one, myeloproliferative neoplasm, which is 39%, APLA, that is 25%, hyperhomocystinemia, which is 22%, inherited thrombophilias, most commonly factor V leading, which is 21%, and paroxysmal nocturnal hemoglobinuria, 19%. Now, all importantly, autoinflammatory and autoimmune disorders like Behçet's and sarcoidosis have also been reported Behçet's at 2.5% and sarcoidosis at 1%. So, as you can see, by far the most common four causes are your myeloproliferative neoplasms, APLA, homocystinemia, and your inherited thrombophilias. So that is MAHI. Okay, and importantly, if you include paroxysmal nocturnal hemoglobin to it, that's almost all causes. Now, therefore, all such patients should undergo workup for MPNs, myeloproliferative neoplasms, APLA, and hyperhomocystinemia levels, thrombotic profile levels. Otherwise, I never will ask for thrombotic profile levels. But in case of Budd-Chiari syndrome, you should always get a thrombotic profile level and PNH. Okay. Renal vein, adrenal vein, and superior vein is a mesenteric vein obstruction, and indeed also your splenic vein obstruction have very similar etiological profiles, except that the most common cause specifically is dehydration with or without pregnancy in a pregnant patient, and or infective thrombophlebitis. So hepatic vein being after the liver doesn't typically have infective thrombophlebitis, whereas other venous drainages within the abdomen obviously are directly draining that parenchymal organ, so they can get affected by infection and dehydration. Now, clinical presentation of Budd-Chiari syndrome is divided into actually four types of patients. One is fulminant Budd-Chiari, second is acute Budd-Chiari, third is your subacute Budd-Chiari, and fourth is your chronic Budd-Chiari. And this is actually based on the biopsy findings specifically, but it can be inferred from clinical presentation. So fulminant would be onset less than 2 months. Acute would be onset more than 2 to 6 months. In our case, the patient had symptoms for 6 weeks, so that could technically be fulminant. Two acute, but these are not hard cutoffs. Okay, more than 6 months to an year would be subacute, and chronic would be more than a year. Like I said, these are the clinical presentations are more indicative, and what we're actually inferring is the biopsy findings. Okay, so the classic triad is a patient of acute and fulminant is a patient with right upper quadrant pain and hepatomegaly with 10 ascites. Additionally, there is an elevation in ALT by more than 3 times, so 5 times upper normal limit, with, in case of fulminant, the development of hepatic encephalopathy, which our patient did not have, and in case of acute, the absence of hepatic encephalopathy. So, likely our patient has acute Budd-Chiari syndrome. Acute Budd-Chiari syndrome. Okay. Now, in case of more chronic cases, what you end up getting is you get ascites and you get development of portal hypertension with portosystemic shunting. Now, in case of fulminant, there is prominent hepatic necrosis. In case of cirrhosis, in case of subacute and chronic, there is no hepatic necrosis. In case of acute and fulminant and acute Budd-Chiari syndrome, there is no cirrhosis, but it is maybe present on 50% of cases if you are using your histopath as a marker. Cirrhosis is present in cases of subacute and chronic. Okay. Now, just let's review the vascular disorders and of the liver, because I cannot think of a better location to do it in. So what we have here is the zones of the of vasculature. So we have this is the branch of the portal vein. This is a branch of the hepatic artery. This is a branch or tributary of the biliary apparatus extra in the portal tract. Now, as you know, blood comes into the hepatic sinusoid from the portal vein and from the hepatic artery, around 20% from the hepatic artery and around 80% from the portal vein in terms of volume per unit time. and goes through the hepatic sinusoids, drains into the hepatic vein tributary, which will eventually will go and form the hepatic vein. So if you look at the partial pressure of oxygen, it is maximum here, maximum partial pressure of oxygen, whereas the this has the least partial pressure of oxygen, because the is being used by hepatocytes as you go away from the site of of, of where the blood is coming from. So this is then called zone 1, this is called zone 2, and this is called zone 3. So when you have any type of decrease in partial pressure, this is zone 3 that is affected first, followed by zone 2, followed by zone 3. So that's your basic vascular anatomy of the liver, functional anatomy of the liver. Now let's talk about the hepatic vascular disorders. So, like we've seen, the hepatic artery can be affected, the hepatic vein can be affected, and the portal vein can be affected. Okay. So, what is the mechanistic effect here? Because the hepatic artery only supplies is the only blood supply of the biliary apparatus, that is the hepatic this thing ducts, as well as the portal venous ductules. Once there is blockage to the hepatic blood flow, these canals completely become ischemic and they are obstructed. So as a result, there is back up of bile into the in the liver, and as a result, you end up getting a obstructive jaundice. Now, in case of hepatic venous obstruction, as in Budd-Chiari syndrome, we have increase in pressure within the hepatic vein. Now, when that happens, there is a back pressure passing into the hepatic sinusoids, and that compresses the hepatocytes on either side. Now, when it compresses the hepatocytes on other side, we know that within a cord of hepatocytes, the bile is secreted into a space in between those hepatocytes, and then it drains into the biliary canonical distally. Now, if there is an increase in pressure here, there is appears to be an obstruction here. Now, obviously, hepatocytes, there is no cause of obstruction here that normally occurs. So the hepatocytes infer an obstruction more distally. Okay, and there is a signal that passes through the hepatocytes through cell to cell signaling, and eventually reaches the distal portal the or distal tributary of the common bile duct or the hepatic duct, and that causes portal uh, hyperplasia of the ductules, okay, of the biliary draining structures, bile draining structures. But the bile draining structures getting increasing number here is not going to reduce the obstruction here. So this is a useless reaction, and nothing really happens. There is no compensatory response that occurs. But when you check the liver enzymes, you find that because there is a significant increase in the number of proliferating biliary epithelial cells, there is an elevation in serum ALP. Now, depending on how severe this obstruction is, you may or may not have necrosis of the surrounding hepatocytes. And as we've just seen, in case of fulminant and acute Budd-Chiari syndrome, often the ALT levels are more than 5 times UNL. Okay, but that is due to hepatocyte necrosis. It's not just due to this obstruction. The obstruction causes back pressure and decreases blood flow so significantly that the hepatocytes in zone 3 and zone 2 become necrotic. Okay, so that is the definition of acute and fulminant. Now, in case of portal vein obstruction, what happens is that the blood flow is 80% from the portal vein, but then the hepatic artery is able to compensate. Because the hepatic artery is able to compensate, there is usually a initial compensation and nothing really happens. But eventually, because the hepatic artery is not the flow through the hepatic artery is not as much as that through the portal vein, eventually there is atrophy of the hepatocytes within the zone 3 of the liver. So that is what ends up developing. So when you look at the liver enzyme pattern, in case of hepatic artery obstruction, you do get an elevation in ALT, that is specifically a marker of hepatocyte damage, but it may be normal. But mostly what is elevated is the ALP and GGT, and you can indeed get very high levels of bilirubin also. So it is a differential diagnosis of obstructive jaundice. Then in case of hepatic venous obstruction, what we end up getting is a definite elevation in ALP levels and a variable elevation in ALT levels. So the hepatocytes may or may not be damaged. In case of acute and subacute Budd-Chiari syndrome, they are usually very highly elevated. So even though I've not discussed the liver function test in our patient, we would suspect that our patient would have elevated ALP levels and and reasonably elevated ALT levels as well. Okay. Finally, in case of portal vein obstruction, we would have a essentially normal liver function enzyme. There may be mild elevation in ALT, but usually that is also not there. In terms of evaluation of the inflammatory pathology, so we've discussed the vascular pathology, that is venous drainage of the liver. We have discussed hepatic artery obstruction as a cause of biliary obstruction, but we've also discussed in general the causes of biliary outflow, obstruction to biliary drainage of the liver. Now we're going to talk about the third thing, that is the inflammation of the parenchyma of the liver. Now, we basically divide these patients into two categories. Uh, Acute hepatitis, that is less than 6 months, and chronic, that is more than 6 months. For this, we use something known as the R factor, which is the ratio of the serum ALT to the upper normal limit of ALT. So in most labs, it's around 40. So say the serum ALT has gone to 120, this ratio would be 3. Now, in case of this entire thing is then divided by your ratio of the serum ALP to the upper normal limit of ALP. So that depends, but 120 is usually the ALP value. So say the ALP has become 240, the ratio would become 2. So in our case, this would be ALT of say 120 divided by 40, the whole divided by ALP of say 120 divided by, or sorry, rather, an ALP of 240 divided by 120. So that would come out to be 3 by 2. That would be 1.5. Okay, so that's how we calculate the R factor. Now, in case of the R factor, we divide cases, in case of acute hepatitis, we divide patients into two categories. One is an R factor of more than 2, the other is an R factor of less than 2. So in case of acute hepatitis, the cutoff is 2. Okay, we call more than 2 hepatocellular / mixed and less than 2 cholestatic. Now, in case of hepatocellular or mixed, the suspected pathology might be an acute viral hepatitis, in which case we could do IgM serology for hepatitis E and A, although it's not always necessary because we're not going to change treatment. We should do HBeAg and IgM HBc for hepatitis B virus and HCV RNA. Although, again, it depends on the clinical severity because most cases with HCV or acute HBV are not going to progress to chronic. Okay. Now, we should suspect infectious mononucleosis, in which case we do a heterophile antibody or monospot test. This early in the course, you don't really do EBV specific serology. You can, but there's no point. It's not going to change treatment. Then we can consider acute autoimmune hepatitis, especially if there have been recurrent acute episodes of acute hepatitis, or it is otherwise unexplained. So then we do an ANA by IFA, and then we send hepato and autoimmune hepatitis serology. We'll come to that in detail when we talk about autoimmune hepatitis. Then we also need to worry about Wilson's disease. So we send serum cellular plasmin, but importantly, serum cellular plasmin is decreased in only 50% of Wilson's cases. So ideally, you should still use 24-hour urinary copper as your screening test. Importantly, you should not send the 24-hour urinary copper in case of cholestatic pattern, that is in case of R factor less than 2, because that would show a false elevation. Now, if it is cholestatic, you do an ultrasound, rule out an obstruction. Now, if you are doubtful, you could further delineate biliary anatomy using an MR, that is MR cholangiopancreatography and or an ERCP. And if both are normal, then we shall look at the serum levels of AMA to look for primary biliary cholangitis specifically. Now, the second thing is chronic hepatitis. So, in case of chronic hepatitis, 4 factors are taken into account: the R factor, the other LFT findings, the PTINR as an indicator of hepatic synthetic function, and serum albumin as an indicator of chronic or long-term hepatic synthetic function. So the first thing that we can have is a hepatocellular derangement of an enzyme derangement. That would be an R factor less than an R factor more than 2. Then we could have a cholestatic pattern of hepatic enzyme derangement. We could have isolated elevation in serum ALP, and we could have elevated serum indirect bilirubin. So that would be a hepatocellular pattern in case of chronic is specifically more than 5. In case of cholestatic, it is less than 2. So in case of acute, the cutoff is just 2, whereas in case of chronic, we say 5 and 2. Okay, more than 5 for hepatocellular and less than 2 for cholestatic. Other LFT findings depends on the severity of the pathology. In case of hepatocellular pattern, because so much hepatocyte damage is occurring, usually we have an elevation in the PTINR, which is not corrected by giving vitamin K. With cholestatic disorders, often the PTINR derangement is less severe and therefore corrected by supplementation with vitamin K. Serum albumin levels may be low depending on chronicity. Cholestatic diseases very rarely cause secondary biliary cirrhosis, so usually albumin is not that low. The R factor in case of these two pathologies, that is isolated serum ALP and this thing elevated serum indirect bilirubin, are variable depending on what is the LFT findings. But here we say an isolated elevation in ALP is significant if it is more than 4 times the upper normal limit. And elevated serum indirect bilirubin would be total bilirubin less than 5 milligram per deciliter with direct bilirubin less than 15%. Okay. Now, in case of these two disorders, the pathology is not really in the liver, so the PTNR will be normal and the serum albumin levels will also be normal. Okay. So in case of hepatocellular pattern of liver enzyme derangement, the causes would be any cause of chronic hepatitis, viral, autoimmune. Okay. It could be in case of cholestatic pattern liver enzyme derangement, it could be any cause of CBD or portal tract obstruction, which we've already discussed. So I'm not going to go into that. Uh, in case of isolated ALP elevation, it is basically a portal tract infiltration. Okay, again, we've gone into some detail regarding this, and I've already in previous discussions on say chronic non or rather chronic focal consolidation already discussed causes of tissue infiltration. It's very analogous to that. And then obviously elevated serum indirect bilirubin with a total bilirubin less than 5 is hemolysis. So this we'll be discussing as separately as in an approach to anemia. Okay, so these will be separate discussions later on. They come across in while evaluating chronic hepatitis, so I had to mention them here. However, they have a significant amount of separate evaluation that is required in each particular case. Okay, so finally, and then there's Gilbert syndrome. Now, drug-induced liver injury can cause all 4 patterns, and that is again a discussion in its own right. So we'll discuss that on later. Right? So now, finally, just analyzing our case that we discussed in the beginning, there are certain other important things that we saw in the case that I had not highlighted earlier. The first thing was progressive diffuse abdominal distension, that is, there's significant ascites, and that will make it much more likely to be hepatic venous outflow obstruction. There was no jaundice, that is, there was no icterus. So, hepatitis, okay, biliary outflow obstruction is very unlikely. Hepatitis is still a possibility, but it is less likely in this particular case because of the severity of the cirrhosis or how tense large the cirrhosis, sorry, rather the severity of the ascites. Okay, so my putative etiology for the syndrome would be the presence of significant ascites in the absence of significant hyperbilirubinemia or AST/ALT elevation. Person without simple cirrhosis basically imply hepatic venous outflow obstruction. There could be sinusoidal outflow obstruction, but he's not had this patient has not had any chemotherapy, and obviously the genetic causes are very rare. Um, or more likely it is Budd-Chiari syndrome versus right atrial pressure elevation. So that is where imaging comes to the fore, and that we'll be discussing in one discussion from now, that is in part 2.6 in this series. Okay, so what we've discussed today is we've compared and contrasted the 7 causes of pain arising from parenchymal organ capsular distension. That is hepatic biliary obstruction, venous obstruction, diffuse inflammation, splenic rapid increase in splenic size versus infarction, renal diffuse inflammation, infarction, and outflow obstruction of urine, distension of parenchymal organs due to parenchymal bleeding, We've described how distension of parenchymal organs due to parenchymal bleeding can cause abdominal pain. We've enumerated the causes of biliary outflow obstruction and made an analogy of that with urinary outflow obstruction. We've enumerated the causes of hepatic outflow obstruction with a specific emphasis on sinusoidal obstruction syndrome as well as Budd-Chiari syndrome. We've reviewed the clinical presentations of various vascular disorders of the liver, and we've reduced the causes of diffuse hepatic inflammation and divided them into acute and chronic. So that brings us to the end of this screencast, and thank you for watching.